Good afternoon, and thank you for joining us today for Expert A Look at Military Populations. We're going to be beginning in about 1 minute. Good afternoon. Thank you for joining us today for Expert A Look at Military Populations featuring Ariel David. We're going to be beginning momentarily. Good afternoon, and thank you for joining us today. Today's webinar is titled Expert A Look at Military Populations featuring Ariel David. I'd like to go over a couple of housekeeping items for today's webinar. Firstly, we'd like to encourage you all to participate in today's webinar via three methods. First, if you have any questions for our presenter or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Halfway through the webinar, we'll stop for questions, at which time I will read aloud any questions that have been submitted to the chat box or the questions pane. You can also use the raise your hand feature to request to be unmuted. Once you create this request, go ahead and unmute your personal phone or mic, and I, as the organizer, will unmute you as well so that you can speak directly onto the webinar to voice your question. You're also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. Now, 1 hour following today's webinar, you're going to receive an email from us with the evaluation and continuing education request information. This webinar is approved for 1.5 PCB and/or NADEC credits. You can also request a general certificate of attendance. I'll go over all of this again at the conclusion of today's webinar. Now, at this time, we'd like to go through some poll questions to get a demographic picture of our audience. Our first question is, what is your current professional role? Are you a counselor, therapist, social worker, or case manager, a nurse, nurse practitioner, physician, or physician assistant, a program or unit administrator, a university student or faculty, or other? And if you select other, feel free to use the questions box or the chat box to let us know what your professional role is. Okay, great. I just want to thank everyone for participating in that poll. I'm going to go ahead and share those results with you. So it looks like the majority of our audience is either a counselor, therapist, social worker, or case manager at 56%. Our second highest percentage is a program or unit administrator at 19%, university or student faculty at 11%, nurse, nurse practitioner, physician, or physician's assistant at 3%. I've also had someone share with us in the questions box here that they are an expert specialist and a contract administrator. For our second question, which field do you represent? Do you work in mental health, addictions, physical health, education, or EAP? And again, if none of these apply to you, feel free to use the questions box or the chat box to let us know what field you represent. Okay, great. I want to thank everyone for participating in that poll, and I'm going to go ahead and share those results with you. So it looks like the majority of our audience does work in mental health at 46%, and our second highest is in the addictions field at 37%. We also had 2 people communicate through the questions box that they work with the National Guard, work with homeless veterans, and work in co-occurring disorders and mental health and addictions. For our third question, do you currently conduct expert interventions? Okay, great. I want to thank everyone for participating in that poll as well. And for those results, looks like 82% of our audience has selected no. And for our final question, do you see your agency using expert? Okay, great. I want to thank everyone for participating in those as well. And again, feel free to share any questions throughout our webinar via the questions pane. And for those final results, looks like 71% of our audience has selected yes, they do see their agency using expert. Now at this time, I'd like to introduce our speaker for today, Ariel David. Ariel David is the project coordinator of the Armed Services Network of Louisiana, an initiative by the Community Coalition, the Jefferson Parish Alliance of Concerned Citizens, to address the needs of Louisiana service members and veterans. Previously, Ariel served on active duty in the United States Navy in the fields of aviation and combat operations and received multiple awards for her military service. Now, after spending 9 years in the military, Ariel now focuses on participatory-based research in coalition building and community advocacy, with a special focus in the behavioral health of unique subpopulations. She currently serves on the board for ETC and is actively involved with multiple national military organizations. So with that, Ariel, I can go ahead and turn things over to you if you're ready to go.
Yeah, great. Thank you, Sarah. Appreciate it.
Okay. So
hello, everyone. My sound all right? Are we good to go?
Yep, you're good. You should just have that presenter pop up. Okay, right, that looks good.
So we should be, so today I'm gonna do a really brief, not brief, well, there's so much information, but I'm gonna try and do a brief overview of, the military population, military and veteran populations, specifically looking at some of the more nuanced aspects of military service and how that relates to substance abuse and prevention, mental health related issues. Let's see. So our goal for this session is we're going to briefly summarize our basic, some basic military cultural competency, just sort of like lay the groundwork for, what I'm talking about and the populations I'm talking about. I want to explore and identify a few nuanced trends in substance use among the military and veterans, and I want to address access to and disparities in health services. I think this is really important to when we're discussing what's going on within the military and among veteran populations. I think it's very important to make sure we include in that conversation what disparities we're seeing in accessing our health services. There are some really unique ones based on gender and race and ethnicity. So I think I want to make sure we at least touch on that for a little bit. First and foremost, I want to define who. I think it's very important for every organization, any agency that's working with veterans and military to define who they're actually providing the services to. This is important because a lot of times in a lot of the research and data that we collect, traditionally speaking, basic eligibility for being quote-unquote a veteran is you have to have served in the military for 24 continuous months or for the full period of which they were called to active duty in order to be eligible for services. So this has to do with if someone is eligible for VA services or if they're defined by the Department of Defense as a veteran. For the purpose of this session and the definition that I traditionally use, it's basically a veteran is defined as any person who has any sort of prior service in the United States Armed Forces. A service member would be defined as any person who is currently serving in the military, which would include the Army, Air Force, Marines, Navy, Coast Guard, and it would include anyone who is on active duty in any type of reserve status and in the National Guard. This is very important because when we're talking about, it depends, depending on what type of agency you are, if you're providing, perhaps out-of-network services for veterans through the VA or through TRICARE, it's very important that you define who you're talking to based on, in order to define eligibility. A lot of times what I see with some agencies that are providing services is they'll have someone who calls themselves a veteran and perhaps are referred there by another service organization, but the facility may or may not be able to provide those services because they're not legally deemed eligible according to the VA or the DoD or TRICARE. So just to keep that in mind, in terms of, when I'm speaking, when I say veteran, I'm defining that as anyone, regardless of eligibility. I think it's important to keep in mind that, only 8% of the United States population are veterans, and less than 1% of the United States population overall is currently serving in any branch of the military, active and reserve. When we talk about competency, I want to go over just some of the very basic military and veteran issues and distinctions. So I want to make sure we touch on, the distinction between the branches, standards of performance for military members, dependents of military and veterans, unique subpopulations, and our gaps in service, gaps between the population overall. There's a lot of, because we're talking about such a small percentage of the United States population, I think there has a tendency to be a little bit of, there tends to be a little bit of miscommunication, and also, the military and veteran populations are often quite sensationalized. So, everyone has, a general idea of what does a veteran look like, who are these people that we're providing services to, or who do we expect them to be versus, what's actually going on. First, the one thing I tell people all the time whenever I do any kind of training with agencies who are providing services to military members or to veterans is that please know the difference between branches. And I want to give an example of this. A few of my staff were conducting some interviews actually just last week, and they kept referring to this client as a soldier, and they were asking specific questions, but they kept coming up that they were referring to him as a soldier, and in reality he served in the Marines, and he was really offended by that. He actually, wrote down not like a formal complaint, but he was like, this bothered me that this person kept calling me a soldier. And I think that's very important, because when we're talking about, when we're already talking about a population that has a difficulty accessing a lot of the services that we're trying to provide them in the mental health and behavioral health field, we don't want to do anything that could possibly, deter them from, calling and self-referring or, reaching out to ourselves as service providers. So that's one thing I always want to emphasize, that we need to know the difference between the branches. It's also very important to look at that we're seeing in the behavioral health field between enlisted individuals and the officer ranks. Those are two drastically different types of service. And population-wise, enlisted tend to be younger. The majority of them are under the age of 35. And they're usually undereducated, of a lower income. While our officers are generally more male, usually over the age of 32, and of course have a higher education level, usually at least a 4-year degree. Okay, so when we talk about families, I think this is really important, because I'm going to really emphasize the current family members of military. If you are an agency that is providing services to, or if you're a TRICARE, I'm not sure if anyone here is a TRICARE provider, out-of-network provider, or even a network provider, but if you are, I think it's important to keep in mind that the majority of military members, are actually married. So we have over 53% of all service members across the board are married, and the majority of them have children. And usually we're looking at, when we look at age, we're about, I think it's right around, let me look real quick, about 40% are under the age of 30 in terms of spouses, and on average have 3 children versus the traditional, so it's a lot younger than most people expect. This is just a really basic breakdown of what we're seeing in terms of ages. I didn't include the children, like information about children, but if anyone is interested in hearing about that, you can definitely email me or email, Loretta, and I can get you that information. I really want to touch on unique subpopulations, and this is because, this is my specialty. We are seeing really unique differences between these populations and the traditional military, the average military force. Women in the military are actually women overall are joining the military at higher rates than any other population currently. Right now we're seeing around 16.5% of our current military force is female, and about 11% of all of our military who has deployed are military women who deployed to the Middle East. This is very important in terms of talking about the role of women in combat and how do we define combat and what's actually going on in terms of accessing services post-deployment. I want to emphasize that, oh, wait a minute, I'm not going to the next one. Hold on, sorry. I want to emphasize that women are more likely to be women of color when they join the military. There's a huge disparity in actual recruitment rates, and also among women veterans. There's a huge disparity in terms of race and ethnicity. Women in the military are more likely to only serve their first enlistment, or the first term, which averages around 4 to 5 years. They're also less likely to enroll in VA services. Those numbers have been increasing slowly over the past couple years, and the VA is doing an amazing job doing outreach to women veterans. But if you are an agency that's providing any type of behavioral health services to veterans, I think it's very important to take that into consideration, that women are more likely to not be referred by the VA. They're more likely to self-refer and seek outside treatment. That's the same for active duty women. We're seeing an interesting trend of women who are covered under TRICARE, and who are, traditionally that military population would be seen by on-base clinics, TRICARE providers, but we're seeing active duty and reserve women choosing to self-refer and pay for their own treatment services well, I've self-reported, and a lot of what we've seen is they're not comfortable with what's being provided. I think it's really important to acknowledge that race and ethnicity is a huge thing in terms of accessing services right now. We're seeing that women of color are more likely to receive a negative discharge than any other population. This is really interesting in looking at who's accessing VA services, or who's eligible to be defined by that traditional veteran definition. Women of color are more likely to be separated with an administrative discharge, or other than honorable versus a traditional honorable discharge. Also in regards to LGBT, with the repeal of Don't Ask, Don't Tell, which was implemented in 2011, it was signed in the end of 2010, implemented in 2011. The DoD just started releasing some of the preliminary data they started capturing on the LGBTQ community within the military. All of that is really new, and they need to do, they're starting to do a lot better job at collecting and looking at. We're seeing a lot, we're seeing in the preliminary research, what we're seeing is that lesbian and gay and queer identified individuals who are actively serving, either active duty or reserve status, they are self-reporting that services are not comprehensive or inclusive, current services. I think that's, as someone who served in the military under Don't Ask, Don't Tell, I can definitely see how that happens. The military has not done a very good job at implementing new policies in terms of their treatment providers, both on and off base, regarding competency. So I think that's definitely something to take into consideration, and when you're providing services, what, in terms of even basic things like forms and, policies around, staff questions. Also with the repeal of Don't Ask, Don't Tell, it did not include transgender veteran service members. However, that repeal is set to go into place the end of this year. If you are an out-of-network provider, the likelihood that you would be affected by that is actually higher than if you are a network provider for TRICARE or the VA. I know that in preliminary, well, in the current conversation on the DoD level, in terms of treatment services, instead of revamping their current policies and stuff, the plan is currently to refer out for all services regarding transgender service members. And a lot of people don't realize that there are currently actually quite a few transgender service members serving, actively serving both in the Reserve, National Guard, and the active duty branches. We have right around 32,000 right now. So definitely keep that in mind. Right now there is no data collected on transgender veterans, so we unfortunately can't really capture that. It's also the data that is available on the lesbian and gay and queer community regarding veterans is also very, it's very limited, and I would say it's definitely underrepresented in the reports that I've seen. So in terms of bridging the gap between military members, veterans, and civilians, the civilian sector, I think it's very important to keep in mind as a provider that the military members and veterans that often are reporting to us that they just don't realize that there's resources that are available to them, or they're not aware of eligibility. I think outreach is extremely important for any provider who has a population of military and veterans in their area, and also ensuring that you are culturally competent to their needs. Especially if you're seeing, we have different areas around the country that have very dense populations of veterans. For instance, we know that in San Francisco there are some really dense populations of veterans, and especially of LGBT veterans. Or in New York City, we're seeing, or outside of New York City, a little bit north of New York City, we're seeing really dense populations of male veterans. So I think it's really important to look at what your population is, your age ranges. We're seeing specific trends in terms of younger veterans where they seem to be migrating to. That's one thing that we've been tracking. I could do an entire presentation just on that as to where we're seeing post 9/11 veterans living and choosing to go after they get out of service. Traditionally speaking, veterans would return to the home of record, and we're not seeing that anymore. It's really interesting. Does anyone have any questions right now that we can?
So we don't have any questions. We don't have any questions right now, but I just want to remind the audience that you are welcome to submit any questions to the questions box or the chat box.
Okay, great. All right, I'm going to go into some of our substance abuse trends that we're seeing. But before I do that, I really want to emphasize that war is trauma. I like to say that in war and in any type of conflict, there are no unwounded soldiers or sailors, any of the above. I think that's really important to keep in mind, given that technology and war and conflict, organized conflict, has evolved. A lot of researchers would argue that the very nature of the military is traumatic, and I'm inclined to agree with that in terms of mental health. We have to really take into consideration that the military is a hierarchy, and it's a closed hierarchy. So accessing outside providers, being able to access and understand the exposed, or at least be exposed to the realities of military service. It's very difficult. We know for a fact that all military members are at extremely high risk for exposure to a trauma during times of war. But because of how war has evolved, I think it's becoming harder and harder for us to define combat and define conflict. I'm always going to say that more studies are needed, further studies are needed to better understand the effects of these on individuals, especially when we're talking about things like PTSD and co-occurring disorders. I think it's definitely something to just always keep in the back of your mind that combat doesn't necessarily mean a direct. When we talk about PTSD and trauma, combat doesn't necessarily mean someone looking at someone else and pulling a trigger anymore. War has evolved, and our thought process around combat needs to as well, especially as providers. All right, so I want to talk about, with PTSD, I'm gonna go over. I really want to touch on this because it's very prominent among veterans and military members who are also using. We know for a fact that women in the military are more likely to develop PTSD than males. And about 20% of women veterans in the conflicts of Iraq and Afghanistan have been diagnosed with PTSD. I really want to talk about how in the past, diagnosis of PTSD was very narrow. It was, our understanding of it was very broad, it wasn't very clear. We didn't realize a lot of what was going on. So I think we're going to see a lot of those rates go up. I think these are very subjective rates. We also know for a fact that individuals who did not see what the military classifies as direct combat, we know for a fact that that individuals who did not see quote unquote direct combat are actually more likely to be diagnosed with PTSD versus someone who actually was a boots on the ground individual and serving in direct combat. So I think we need to be very careful when you're dealing with, or at least take that into consideration, that PTSD is no longer confined to that idea of men running into battle, because that's not what war is anymore. I also want to emphasize, because I'm gonna touch as I go through this section, I'm going to talk a lot about women, because there are some unique differences between men and women serving in the military, and what the outcomes that we're seeing. I want to emphasize that women have served in combat for years. I know that a lot of people would probably assume that that's not the case, but a lot of times, I know the repeal on women in combat just went into place last year. However, women have served in combative operations for decades. It has always been bureaucratic maneuvering that's allowed the military to utilize women in places of combat and places of conflict without necessarily recognizing their role. And I'm going to give an example of that. So the last time I deployed when I was on active duty was in 2009 to Iraq, and I was in a combative role. However, as a military member and as a woman, prior to the repeal, for lack of a better word, prior to the repeal of allowing, with women in combative roles, I was technically classified as a defensive operative. So even though I worked side by side with men and I performed what was defined under their role as a combative operative, I was considered defensive. So women so I just want to emphasize that women have always served in combative and conflict roles. It's just a matter of, it's all about linguistics and all about what the military has and hasn't acknowledged the roles to be. So with substance abuse, in 2014, that's the most recent report that's been published, we were seeing around 11.7% rate of prescription drug misuse among the branches. That's extremely high compared to the civilian rate, and this was reported by the DoD and Institute of Medicine. Since 2004, alcohol use among military members has increased 33%, and prescription drug abuse has quadrupled. Self-reported rates of use are 18% regarding heavy alcohol and 12% around illicit drug use. Once again, I think we need to be really careful and of course look at the data that we have subjectively. The military is trying extremely hard to address the issue of their prescription drug use and misuse across the board. Previously, I would say back until about 2012, when there was a lot of awareness being raised about, what's going on with prescribing practices within the military. Previously, the military had, with the military, it's all about operational security and operational success, right? So what the military was doing, they had a tendency to be prescribing a lot of opiates to individuals in order to create what they called operational readiness and unit readiness. Basically, it was cheaper for the military to give someone a prescription than it was to send them to treatment. And this is extremely important to acknowledge, especially with the what was called the stop-lossing that was going on. So basically, with individuals being deployed multiple times consecutively. This is the first time in history that we've had so many individuals who served in the military serve multiple, such long and consecutive deployments. Most people who deployed in the military since 2001 deployed at least twice, and that's never happened in the past. Once again, when you're talking about things like PTSD and, I think it's really important, and trauma, it's really important to take that into consideration, that we really haven't had a baseline to compare what's going on today with what happened in the past or during past conflicts. So right, there's the self-reported rates of use. So among veterans, so that previous slide was about currently serving military members. Among veterans, the NISA reported these rates. This is obviously alcohol use. We're seeing 41 to 56. Male veterans are more likely than female veterans to do any of the following: alcohol use, binge drinking, and heavy drinking. This is all within NISA, self-reported. So also, I wanted to mention too, I don't have the slide in here, and it's because it's like 100 different graphs, and I didn't think they would look very good. But when you're talking about the prevalence of drug-related disorders, alcohol and drug-related disorders among military dependents and veteran dependents, so family members, we're just starting to try and capture that. It wasn't until 2008 that the DoD started tracking that. Their first report was in 2012, and once again, it's been very hard to try and capture what's going on with the family members on all levels. Okay. Let's see what else I wanted to. Another. Okay. There we go. Sorry about that. Once again, so back to prescription drug use. This is huge. This is one of the, well, at least for my agency, this is the thing that we see the most among our military members, this and alcohol. There are major gender differences regarding drug use between the branches as well, and I want to make sure I emphasize that. So overall, 11.5% overall of prescription drug misuse. Prescription drug abuse among women on active duty is 13.1%, and that's 4 times the rate for civilian women. Women in the military are also, on average, have on average a higher rate of past month use compared to males in the military, and that's the same with veterans. They have women veterans have a higher rate of past month use. Except for in the Marine Corps, women in the military tend to be more than likely than male counterparts to use illicit drugs. And we know that women in the Army are twice as likely than men and women in the Air Force, Coast Guard, and Navy to have used any illicit drugs, including prescription drugs in past month usage. So depending on if you're a service or a treatment provider, something to take into consideration is what type of military branches you have in your area. If you're close to a Marine base or a joint services base, those are things to definitely look at, because you're going to see differences. You're going to see huge differences across the board in terms of the Marines versus the Army and the Navy, and you're also going to see differences between bases that have actively deploying individuals versus like a joint reserve base. All right. So to keep on this about, So I want to emphasize this too, and as a treatment provider, you keep this in mind. From 2009 to 2011, this is how many people, 378,000 individuals were discharged from the military. 1 in 12 had active prescriptions, and it was right around, the average was 4 active prescriptions when they transferred out of the military. When people were transferring out of the military, since 9/11, so basically post-9/11 veterans are more likely to be younger, they're more likely to serve, they're only a first term basically, which is usually 4 to 5 years, and then they usually get out. So on average, these individuals would get out and be under the age of 30, and 1 in 12 of them were having active prescriptions, or at around 4 prescriptions. Now, the military and the VA, just because you serve in the military, you don't automatically get transferred to the VA. Anyone who's worked with military populations in the past or veteran populations in the past should be aware that it's a huge ordeal. The process to become, receive services at the VA is much too complicated, and there's been tons of controversy around that already. So what we were seeing, and in my area specifically, so in New Orleans, what we were seeing is we were seeing young people get out of the military with prescriptions and not being able to transfer their prescriptions, basically. So a lot of them didn't necessarily have jobs. The majority of our young people, in our area, the majority of them were men under the age of 30. They didn't necessarily have a job, and they didn't necessarily have family in the area. So in the work that we were doing, we were seeing basically our veterans were going to heroin usage, which, you know, opiates, right? So we had back in 2012, I think it was, we had a large, we had 3 bases, and we had a large group of individuals come back from a deployment. Like, we had several units who had been deployed, and they came back and they transitioned people out of the military. And instead of going home, most of them stayed here. And we could see the correlation in the spikes in usage and in arrest rates and distribution during that time frame. It's really interesting. We did a great report on it. So I think it's like, as a provider, keep that in mind. Please keep that in mind in regards to you know, who you're providing services and to what you're actually doing. I also want to emphasize that there's male veterans and younger male veterans are more likely to live in poverty than all other veteran populations. So we have, and women veterans are less likely than non-women veterans to live in poverty or to be homeless, but the ones that are more likely to have young children. We're also seeing that overall, or at least in my area, and I have the national rates, you know, regional distribution too. In my area, our veteran homeless population has a tendency to be under the age of 40 and male. I don't have a slide on this, but I wanted to talk about real briefly about military sexual trauma. The most recent report has not been released as to last year's numbers, but in 2014, I believe it was almost nearly, it was like a 25% increase from the year before in terms of reports. However, the Pentagon did a study and surveyed active duty military members, and they revealed that it was like right around 26,000 incidences of unwanted sexual contact. So that includes, by definition, that includes anything that is coerced or abusive sexual contact, aggravated assault, and rape. I think right currently, women make up, 16.5% of the active duty forces, but as reported, 47% of all sexual assault cases within the military. And when I say within the military, I'm talking about what we would call basically blue on blue or green, basically military on military assault. I'm not talking about outside the military. And keep in mind, once again, the military is a closed hierarchy. Those types of investigations are all done internally, so it's very difficult for us to get accurate numbers and access to that information. I also have, to go on to that in terms of dependence, the military does not collect information about, they do on minor children, but they don't on spouses in regards to domestic violence. They don't have an annual reporting regarding that. So the only information we have on domestic violence, within military populations, it's usually, I think it's underestimated and it's inconclusive. We have been able to do some area-based research. So for instance, in the New Orleans metropolitan area, we've seen a large increase in neglect and spousal violence rates. So definitely take that into consideration. Look to see if anyone in your area has done that type of research. If not, once again, you're welcome to contact me. We may have done something in your area, so please let me know. And this is even if you're outside of the state of Louisiana. I do a lot of national work too. And just to follow up on that too, when we talk on the military sexual trauma and related information. A lot of people don't realize that during the military surges, as they were called, when recruiting was, very aggressive. Usually, that time frame was about 2003 to 2006. About almost 20% of all military members or people who enlisted in the military came under what was classified as a morality waiver. And this is a very interesting correlation to violence within the military. A lot of people thought morality waiver, most people actually, when I speak with individuals, a lot of times people think that morality waivers had to do with drug use. However, what they don't realize is that, over half of them were convicted felons who enlisted in the military, and that included individuals who were found guilty of more serious charges, obviously, such as, vehicular homicide, rape, statutory rape, unlawful sexual contact, aggravated assault, assault with a dangerous weapon, and such. And, on top of that, once individuals are enlisted in the military under a morality waiver, the DoD no longer tracks that information. They don't have any type of systematic tracking or monitoring of those individuals. Once they're signed up, they're good to go. So there was one agency that's looking at increased, trying to define more clearly where the spikes in sexual assaults were happening and if that had any correlation, which I think will be really interesting to see when they publish next year. Actually, they'll be publishing next year. Oh, and on top of that too, so of those morality waivers, those 20% that were morality waivers, so almost a third of them were what we classify as serious misdemeanors, which are usually assault charges and battery charges on other adults. A few other health concerns I want to make sure to touch on. Depression, we know that women military members are at a higher risk for depression than men, although overall lower substance abuse and misuse disorders. Suicide risk is reported as being lower among women veterans, but standard mortality rate among female veterans is higher. Also, in terms of suicide, most of the studies focus on the difference between veteran and non-veterans versus males and females. So if you're collecting that, if you are doing anything with suicide prevention, try and collect that type of information. If you're doing any type of research, I just want to encourage people to keep that in mind. One aspect about suicide is that we know that women veterans are almost twice as likely to use firearms compared to non-veterans. Women veterans are less likely to use what we classify, quote, non-violent means, unquote. We also know that women who deployed and had combat exposure are twice as likely to develop eating disorders and more likely to use an extreme amount of weight when compared to women who deployed but did not report combat exposure. Overall in the military, and a lot of people don't know this either, overall in the military, men are they're more likely than women actually across the board to develop eating disorders. There definitely needs to be more research on that, and we need to have, we need to have a really comprehensive report done on that, because it's definitely something that, especially when you talk to military populations or working with military populations, the idea that, men would be the ones affected by the eating disorder issues and, problems, they have a tendency to, blow it off, which is really interesting to me, since we're talking about a population that has, strict standards of performance and physical health requirements. So I think that's something to definitely, think about. It's also something to take into consideration in regards to prescription drug use. You know, there are several. I could give several examples of. We had veterans who were or military members who were using specific drugs to lose weight. And yeah, we see that. I see that quite a bit actually within my agency. So definitely think about that. Okay, so accessing services. Once again, I'm not 100% sure. I mean, I saw the types of agencies, you know, what your specialty is, but keep in mind that most, you know, 1 in 10 veterans don't have health insurance and don't use the VA. So we're looking at around, and this is last year's data, 1.3 million veterans under the age of 65 who are uninsured. So, and the 948,000 adults and children, that includes individuals who could be eligible for VA services based on what the military would classify as a disability, and therefore their children could possibly be covered. Once again, I don't have that broken down by gender, but please keep that in mind, especially since women are less likely to be accessing care. And I think I spoke a little bit fast, so I'm a little bit ahead of schedule. I think that's about it for me. Do we want to go over any questions?
Sure. So I have a couple of questions that have come in here. Our first question is, are there active therapists in combat zones as a form of preemptive strike in dealing with traumatic events?
So that's a great question. The military is just recently, in the past few years, started to look at active therapists, clinicians basically being deployed with combat units. Unfortunately, no, traditionally there hasn't been. For example, I'm going to give an example of my last deployment. So I came home in the fall of 2010. There was only on what we called, you know, it was our foreign operating base. There was one clinic at the foreign operating base that we did operations out of, and it was staffed. It only had 3 behavioral health professionals within it. And keep in mind, when we're talking about the military, you know, different bases, some of them have contracted positions, some of them have military clinics, some of them have, which are, you know, all military, staffed by all military personnel. You know, some of them have hospitals and are able to, you know, military hospitals are able to provide a better level of care. But when we're talking about combat zones, honestly, I'm going to say that the military definitely needs to take that into consideration, because usually services are limited. I like the word. I like how you use that in the question, preemptive strike. No, unfortunately, I think that needs to be taken into consideration by the military more. I think there have always been, you know, like what's called pre and post deployment assessments and reviews. You know, where they try to give military members the tools on, you know, the resources that they're going to, you know, to help them in the event of a traumatic, you know, or combative experience. But honestly, it's not comprehensive enough. There definitely needs to be more resources. There needs to be someone available. Unfortunately, just you know, in war, and in combat, that's not necessarily always the case, especially when you're looking at remote locations. You know, out in the mountains and in Afghanistan versus, you know, if you were sitting in a Baghdad airport, you know, there's going to be differences in services and what's available to you.
Okay, so our next question is, why is PTSD more common in non-combat vets?
So that's an interesting question, and there's actually, you know, there's 2 studies specifically being conducted on that. So my perspective on that is that most combat veterans in military populations today, individuals are more likely to be deployed more than once, especially if you are classified as a combat operative, because a lot of people don't realize that only around 6% of the military actually conduct direct combat operations. So when I say that, I mean like actually pull triggers, actually knock down doors, actually do physically combative operations. But once again, we have to look at broadening our idea and our perspective on what is combat. It's been argued, that a drone pilot, someone who sits in the desert of Nevada, are they conducting combat? Because technically speaking, they're not classified as combative because they are not. That drone pilot is not necessarily, even though they're technically engaging in combat, they're not physically engaging in combat. And I think we need to take that into consideration. That's the same thing when we're looking at like secondary PTSD, when we're talking about, for instance, in the hospitals, like in the hospital in Germany, which is where anytime someone was injured in Iraq or Afghanistan, they would immediately be shipped to our bases in Germany. We saw huge rates of medical personnel being diagnosed with, secondary PTSD and other, substance abuse disorders and such. I think trauma, and when we talk about what is trauma, what is trauma, what is conflict, and what does it mean to serve in the military, I think we have to really think about that on a much broader level than we traditionally do. I hope that answers your question. I mean, I could give my opinion as to why an administrative personnel would receive a combat, receive a PTSD diagnosis versus, a combative operative. Like my personal perspective on that is that, combat veterans or people who serve physically in combat are more prepared. That 6%, those are highly trained individuals. They invested, there's a lot of time invested and time and money invested in preparing those individuals for that job. While, an administrative personnel, someone who never left the base, it can be an extremely traumatic event if, their location got mortared. And they're not necessarily in what would be classified as combative, but they just experienced an extremely, an extremely traumatic, unexpected event. And during the early, like 2003, 2004, 2000, through like 2006, like that was extremely common. IED attacks. Even though, what if you're just a personal transport? Like you did personal transport, you're not technically combative, but if your, if your convoy was hit by an IED, you still weren't classified as combative, but you just experienced an extremely traumatic event. You may have watched something. So I think we really have to broaden our definition. I think the military needs to broaden their definition of combat and conflict, and I think as providers we need to look at that and be very conscious of that.
Okay, great. Our next question here is it still hard for active duty to report the need for treatment for substance use disorders? Yes, yes, definitely. And this is going to differ by branch. I'm seeing that the National Guard and Reserves are getting a lot better at providing treatment for self-referrals. But with active duty personnel, when you self-report and request treatment, the military is obligated to give it to you. So once again, going back to things like unit readiness and the monetary value of military members and operational security,
it can be very difficult for a military member who may be looking to perhaps renew their security clearance. If they're going to, that's something that, that would automatically go on their record for, a higher level security clearance. If you're seeing a therapist or if you're on certain prescriptions, that can automatically disqualify you for certain jobs. So definitely. Also there has a, with active duty, while there is, especially if you're being seen by by a military clinician, or if you're accessing services within the TRICARE network, while the military and everyone talks about like privacy of your health records and stuff like that, once again, the military is a closed hierarchy, and usually bases are small. I mean, or dense populations of these individuals. And to be completely honest, like, my last base, my last command, everyone knew everyone's business. Like, if you went to the clinic, like, it's not that someone saw something. So it's very, I think that's definitely a hindrance to individuals self-referring, especially for substance abuse and depression, especially.
Okay. Our next question is, what is the definition of alcohol use and binge drinking, I'm assuming within military guidelines?
Yes. Alcohol use is any alcohol, any use as reported by the service member. Binge drinking is it's different for males and females. I believe it according to the military, and this is, I think it's a little bit different than the civilian sector. In the military, it's 4 or more drinks for women, and 3. No. Let me look at. Hold on. I have it in my notes actually. Yep. It's 3 or more drinks for women and 4 or more drinks for men in a week. I'm trying to think. What was the other one? Perhaps is there another one? Illicit drug use, that is defined as any substance, any drug use that was not prescribed to you. It would include any type of illegal drugs, as well as any prescriptions that were not that were being misused, that were not prescribed to you. Yeah. So I can send like descriptions of on those.
Sure, and we can share those with everyone after the webinar. So our next question is, can you elaborate on why you think the percentage of prescription drug use is higher?
Yeah, once again, I think I'm going to say that goes back to unit readiness, especially during, the surges with the war in Iraq and Afghanistan. It was cheaper to prescribe drugs than it was to actually provide treatment. And just as an example of that, and I came back from my last deployment into the fall of 2010. My post-deployment assessment, health assessment, when 2 days after I stepped off the plane into the U.S., basically what happened was I went to the clinic and they said, "Hey, are you doing all right?" I'm like, "Yeah, I'm fine." And they're like, "All right, well, here's a prescription for sleeping pills. Here's one prescription for anxiety. Here's a prescription for pain, and here's a prescription for a depression." Like, so they literally handed me 4 bottles of pills, and I was like, "Well, I didn't even ask for any." They're like, "Oh, that was their policy. Like, that's not policy, but that was just the way that it worked." Once again, and also on top of that, so when individuals deployed, and this is something that I witnessed when I was in the military, and is still policy to this day, when you deploy to somewhere like Iraq or Afghanistan, if you have a prescription for something already, when you deploy, you're going to receive a prescription for the length of that deployment. And then if you run out when you're in theater, so for instance, if you deploy to Iraq and you were going to be there for 6 months, they would hand you a 6-month prescription for whatever your your prescription was. If you ran out while you were there, you could go to the clinic and just say, hey, I ran out or I lost it, and they would just order you some and it would be shipped to you. So I think the military facilitated their increased rates of prescription drug use. Once again, it was so much cheaper just to give, someone who said that they were depressed a prescription than to actually send them to treatment. Policy-wise, rules of engagement, rules of service, overseas are a little bit different than stateside. So, there's ease of access to prescriptions. Also, the military had a big, the military across the board, all the branches, the DOD, did their whole push, their zero tolerance. But a lot of their, in regards to drug use, but a lot of their focus and campaigning was on, like marijuana and heroin and cocaine, which were the three highest substances, that individuals were testing positive for, before, I'm talking about like in the 80s and 90s. So I think they really honestly just didn't even consider, the idea that, people would be misusing prescriptions, or even if they did consider it, it wasn't a priority for them before. They've definitely revamped their policies in regards to how long you can receive prescriptions for, which is great. I know that their post-deployment assessments are much more in-depth, and now they require not just a post-deployment assessment, but also a 6 and a 12-month assessment prior to, after you come home. Also, their transition, their military, when I was in, it was called, your warrior transition. So you would go to, when you came home, you wouldn't come directly home. You would go, like, in Iraq, I went from Iraq to Kuwait, and there was a 2-week, what was called a warrior transition. So we did a turning in your equipment, a decompression phase, here's a bunch of resources for you. I've heard, and I actually participated in one as a speaker, but they're much more comprehensive now than they used to be. They're still, revamping some of that, there's a new pilot program that they're trying out in Germany, I believe, where they're starting to take, specifically for combat individuals, where they're doing like almost a month-long transition phase, which I think is important because for the longest time it was, come home and here you go, here's your pills, as long as you're good, let us know if there's anything wrong, and they just drop you off. So I think that would be my perspective on that.
This next question you've kind of touched on a little bit, but it's a nice follow-up to what you were just discussing. Who is prescribing different prescriptions while people are on active duty?
So yeah, that has to do with, that depends on the location that the individuals are stationed. Most military clinics have military providers, but military, and the same for if it's a military hospital, they're usually military providers. But overseas, often it's contracted, and depending on the type of base, it's contracted. Or if the base or the location doesn't have a clinic, it's TRICARE network providers. And at times, depending on where you're located, it's the VA. For instance, in New Orleans, the VA, because there is no military hospital and it's a really tiny military clinic that our base has, the VA provides certain services, certain treatment services. And then the rest of the individuals go to network and out-of-network providers, TRICARE providers. So it just, honestly, it just depends.
Okay, our next question is, do you have data or information on sexual abuse on same sex?
Yes, and honestly, I have a lot of data on that. So if if someone is interested in that, I can definitely direct them in the right direction. I can send them in the right direction. We have several reports on, what's going on there. So I can tell you, like, up front that, male-on-male sexual abuse is extremely high, while when we're talking about women, it's tended male-on-women, not male-on-female. So, but if someone wants details on that, once again, I can send that.
Sure, and we can connect you after the webinar here. So our next question is, can you clarify the 20% morality waiver statistic, and are there other significant waivers granted in the post-9/11 period that we should be aware of?
There are a few other waivers that happen. I honestly was never as concerned with the drug waivers that were happening, because the majority of the drug waivers that we saw were related to marijuana, and it was all low-level. The majority of those were low-level misdemeanor usage, like first-time use. Once again, if someone wants to see the report on that, I'd be more than happy to send that out. The 20%, it was close to 20% of individuals who enlisted between the time frame. So it was the time frame that was listed. And yeah, that had to do with, it had a lot to do with the surges. So it was, the military was undermanned. It was right when the war in Iraq was, or the conflict in Iraq was officially starting. We had two primary phases of surges, what was called surges, when we had mass amounts of military members deploying. And the first one, it was in the beginning of the war in 2003, 2004. And then once again, like right around 2008, 2009, there are two mass surge time frames. And that created undermanning. And, recruiting practices were really, honestly, recruiting practices were really interesting during that time frame. Nowadays, you have to, pretty much almost all the branches require a diploma nowadays. Back then it was only, GEDs were required, or there were even waivers for individuals who didn't have either. Judges are no longer, in terms of the justice system, judges are no longer allowed to give defendants the option of military service in lieu of incarceration. That's no longer allowed. But yeah, definitely during that time frame, if someone would like more information on that, I can send them more information.
Okay.
I could do a whole session just on that. So.
Absolutely. Our next question is, sorry, I'm just reading through some comments here. We've had a lot of people provide some feedback on the presentation so far, and just looking at how the military is facilitating substance misuse. So our next question is, are services provided to families whose spouses are transitioning back? For example, family counseling or family therapy? And is this something that is prescribed as needed?
Yeah, so services in the past for family members was extremely limited. Once again, like I said, data was only being collected on, only started being collected on family members and needs and rates of use and stuff more recently. But and once again, a lot of times the services that are available have to do with where an individual is located and the type of so you can elect as a military member. If you're serving in the military, you're eligible for TRICARE, and your family members are eligible for TRICARE. But military members can choose whether or not they have network providers, or whether they only want referrals out in town, or they can be seen by, family members can also be seen by military doctors. I worked with the naval base in Jacksonville for a while, and we thought it was really interesting because almost all of our military families were being seen on base by the military providers versus going off of base, which was interesting to us because some of they didn't have, like, even the clinic that was there did not have like a family counseling available. So once again, that's going to completely depend on the area that you're at, and we don't really have enough information. Once I will say this, that unless a service member is what would be classified over 30% disabled by the VA, if they're eligible for VA services, only then are family members and dependents, as it would be called, the what would be the word for it? Like track and have VA services available to them, certain VA services available to them, once again depending on their location.
Okay, could you talk a little bit more about health insurance eligibility, especially regarding the length of time that someone needs to serve so that they're eligible for health insurance?
Yeah, so in regards to VA eligibility, so for a service member, for a veteran who got out of the military, in order for them to be eligible for VA services, it's going to depend on their length of service. They have to, upfront, they have to have served at least 2 years, or at the period that they enlisted for. So this is interesting, especially when you're talking about National Guard personnel, because traditionally speaking, the VA was not approving services for individuals who deployed for less than 90 days. So if they were not injured within that period, time period. So basically, if an individual was served in the military and they only served 1.5 years of their contract, they may have deployed or not, but if they were never in theater over 90 days consecutively, then they were not eligible for services. That was the most common case that I was coming across. So TRICARE, which is the insurance that that is provided to military members, it does not. You can elect to have it for a certain period of time after you get out of the military, but you are not automatically approved for it. So, for instance, you could be, if a woman had TRICARE and was getting out of the military, and also say got pregnant three months before they transitioned out of the military, her TRICARE would cover her pregnancy, but that's it. If she did not elect to pay for it out of pocket, pay for TRICARE coverage. So most of the time when you're in the military, you can elect to have TRICARE for 6 to 12 months if you cover the cost of it. There's a cost associated. But if something happened, like say, so she got pregnant while she was on active duty still, TRICARE was going to cover the cost of the pregnancy, but anything extra, she would have to pay for if she didn't elect to pay overall. VA eligibility is all subjective. So if someone does not get a disability rating, if you're a post 9/11 veteran and you served, between 2001 and currently, you're eligible for up to 5 years of care, and that has to do with increasing VA access. So even if you don't have, even if you don't have a disability, even if you were not injured ever during your time in service, you have access to that. A lot of veterans don't even know that, though. We're seeing that a lot of times veterans just aren't even aware that that even if they aren't, they haven't gone through the process, that they can show up at a VA clinic and receive services. Or a lot of times, I've noticed this too, a lot of providers aren't aware of how they can, how to bill the VA. That entire process, even if you're not a network or out-of-network provider for the VA, if you have a veteran show up to your agency, you can still bill the VA for that if they weren't unable to pay. it's a process, and it's I can send people information on that as well, as to how they would go about doing that. If there's anything specific, anyone has any question about that, just let me know.
Sure. Our next question is, do you think the stigma of substance abuse is less now in the military than previously?
I don't think, I don't know. I don't want to say substance abuse as much as I want to say, I think the stigmatization around behavioral health overall is, I think we're getting there. I think substance abuse is a little bit, is a little more specific because, I think generally, I remember when I joined, there was still, the old master chiefs and the people who had been in, 40 years already, 30, 40 years, we're lifetime service members, right? And they would talk about the good old days when, they could do a line on their desk, and I was like, and it was never like a huge, like I think like the culture of use in the military is already pretty, that's pretty prominent. Like everyone, like alcohol, there's huge accessibility of alcohol on military bases. For the longest time, even up until I believe it was 2010, unit commanders or command COs could authorize alcohol use at military functions, even if the individuals were underage, which is kind of a big deal. When I joined the military, I remember going to my first ball. And at 17 years old, anyone could drink. Our CO authorized it. So I think when you talk about substance, I think it's not like I think the military itself kind of facilitates use overall. The very nature of what the military is and does, I think encourages it. But in terms of accessing services, I think slowly, very slowly, they're starting to implement more programs that, make it easier to ask for help and make it easier for service members to self-report without risking their service. I mean, it was just last year that they changed the rules around your security clearances, specifically as they had to do with depression diagnosis. So I think it's a slow process.
So I think we have time for one more question here, and then after that I'll go over our continuing education and evaluation instructions. So this last question is, could you speak to the role of chaplains as playing the role of or providing the role of a therapist in combat zones?
Oh, okay. So, not every military foreign operating base, and we're talking about serving overseas. Not every base doesn't necessarily have a chaplain assigned to it. Most of them do, but when I'm talking about bases, I'm talking about, say, in like Bahrain, particularly when I'm going to talk about the Middle Eastern region. But not every foreign operating base in those regions necessarily have a chaplain. In Baghdad, when I was there was 2 chaplains who were assigned, and one of them was also a licensed therapist, which was really interesting to me. You often see overlap of duties there, but once again, chaplains are limited in terms of what they can provide, and also the chaplains have a lot of leeway in terms of they have a lot of leeway. I'm trying to think of the correct way to put this, especially when we're talking about the differences in between men and women, and we're talking about also LGBT populations. The chaplains have a lot of leeway in terms of what they provide and what they don't provide. So keep that in mind when you consider like the role of chaplains on military bases. I hope that
Okay,
answers
great.
the question, sort of.
And if anyone has any additional questions, feel free to send them in to us, and we'll share them with Ariel and then provide her answers to all the attendees. But I want to thank you, Ariel. That was an excellent presentation. Thank you so much for your time and your expertise. At this time, I'm just going to go over some of our continuing education and evaluation instructions. So you're going to receive a few emails from us following today's webinar. Included in them will be a PDF version of today's slides as well as a link to the recording. And there will also be a link to an evaluation question. Now, normally we send evaluations that are a little bit more extensive, although this time we're going to just be using a webinar satisfaction survey. If you want to skip the evaluation, you can feel free to just move straight through it without selecting any of the options. Following the evaluation will be the continuing education request page. You'll be able to request a NADAC or a PCB certificate as well as a certificate of attendance. And all of your certificates are available for download inside your My IRETA profile. So this will be the certificate request page once you've completed your free purchase of either a PA-CADC credit or a NADAC credit. You'll go through the order process, and then your certificates will be available for download within your My IRETA profile page. Now, again, we want to thank everyone for all of their participation today, and if you have any questions following today's webinar, you can feel free to email us at info@ireta.org, and we'll be providing some additional information based on Ariel's presentation today to all of the attendees. So, okay, thank you all very much.